Hello, everyone, and welcome to our program, Best of UEG Week 2022 in Inflammatory Bowel Disease. This activity is provided by Global Education Group and Bonum CE in partnership with Monday Night IBD and the United European Gastroenterology Week. If you haven't already completed your pre-survey, please click the link in the chat or scan the QR code shown on the screen and complete that survey before we start. Let us know who you are in the polling question on the screen. Also, please be sure to complete your evaluation at the end of the session and claim your free CME credit. And finally, please join us this Monday, January 30th, on the Monday Night IBD Twitter handle at 2 p.m. Eastern Time or 7 p.m. GMT for our live Q&A with our IBD experts and guests. This program is supported by an educational grant from Bristol Myers Squibb and AbbVie. I'm Dr. Charabaty, Clinical Director of the IBD Center at Johns Hopkins Sibley Memorial Hospital and founder of Monday Night IBD. I'm joined today by fantastic colleagues from all around the world to bring you this program. We'll have Dr. Miguel Regueiro, Professor and Chair of Cleveland Clinic Digestive Disease and Surgery Institute. Miguel.
Thank you, Aline, and it's great seeing you and everybody today. Thank you for allowing me to participate.
We're also joined by Dr. Iris Dotan. She's the Chief of the Division of Gastroenterology at Rabin Medical Center.
Thank you, Dr. Charabaty. It's great to be there. It was a wonderful UEG, and let's hope that we'll have a wonderful discussion of it now.
Absolutely. And last but not least, Dr. Charles Murray. He's the Department Chair of Gastroenterology at the Digestive Disease and Surgery Institute, Cleveland Clinic, London Hospital, and the Clinical Director for Gastroenterology and Endoscopy at the Royal Free London NHS Foundation Trust. Charlie, thank you for joining us today.
And thank you so much for getting this organised, Aline. So just on behalf of UEG, really happy to be here. Thoroughly looking forward to getting this collaboration going. And I hope you all enjoy it.
Absolutely. Absolutely. So our disclosure are shown on your screen. And upon completion of this education activity, participants should be able to compare study design and clinical trial benchmarks among relevant studies of ulcerative colitis and Crohn's disease and their implication for interpreting results. We should be able to describe efficacy and safety data of emerging agents in clinical trial of UC and Crohn's disease, and select the treatment that optimizes the outcomes of our patients with inflammatory bowel disease based on the known safety and efficacy profiles of current therapies. Today's agenda will feature a top selection of IBD-focused abstracts that were presented at UEG Week 2022. We will start with Dr. Miguel Regueiro, who will review top abstracts that focus on the S1PR modulators, ozanimod and etrasimod, and also a very interesting study comparing two dosing interval of adalimumab. Miguel, the floor is yours.
Great. Well, thank you again, Aline. And as you said, I'm going to present first on the S1P molecules, but then also discuss some interesting new data on adalimumab. So the first study I'm presenting from UEGW is extended therapy with ozanimod for ulcerative colitis in primary non-responders. And really the purpose of this study is to determine the proportion of patients with ulcerative colitis who did not initially respond to the 10-week induction of ozanimod in the True North study, which, as you know, is the pivotal randomized phase 3 trial, but then benefited from additional ozanimod treatment in an open label extension study. And just to put that into context in our practices, this is often asked if a patient's not responding to the first 10 weeks of ozanimod, what happens if we simply continue? So the population of patients were 150 adult patients with moderate to severe ulcerative colitis who did not initially achieve a clinical response to the standard dose of ozanimod, 0.92 milligrams oral once a day by week 10, but then continued ozanimod in this open label fashion. The baseline characteristics of the patients, there were 66% male, 44% had an extensive disease with a mean total Mayo score of 9.2. So what were the results? On the left, looking at symptomatic clinical response, this is the ozanimod cohort 1 patients who did not achieve a clinical response on ozanimod at week 10 of induction and then entered this open label extension. Just to ground you as far as the bar graph, the gray are biologic naive patients. The lighter green blue are those patients who had been on one biologic. And then the darker green blue are the 2+ biologics. And you can see for symptomatic clinical response, the patients who had not responded to the initial induction at week 10, by extending 5 more weeks, you see that up to 63.2% of the patients who had been on one biologic achieved that response, 43.7% of biologic naive, and 37.2% of those that had been on 2 biologics. And then look what happens if we extend out to week 10. Again, you can see that we pick up a number of patients who initially had not responded to the first 10 weeks. Now let's look at the right-hand side, more rigorous endpoint of clinical remission. And what you can see here is by extending 5 weeks beyond the first 10 weeks, 16% of the patients were able to then achieve a clinical remission, and 10 more weeks, 19.3%. So the bottom line is those patients who did not achieve a clinical response after 10-week induction of ozanimod, almost half of the patients achieved a clinical response with an additional 5 to 10 weeks of ozanimod. Interestingly, prior biologic use did not impact the overall symptomatic response. 16% of the patients achieved a clinical remission with 5 additional weeks of ozanimod, and 19% achieved a clinical remission at the end of 10 additional weeks.
Miguel, I would love to hear your thoughts about this because, like you mentioned, nearly half of the patient with UC that continue ozanimod for a few additional weeks achieve clinical response. So my question to you, in your clinical practice, which patient who did not respond to those first 10 weeks of ozanimod you think would be a good candidate to continue for 5 to 10 weeks and see if we get a response?
Yeah, so obviously this is an important study, and then the question is, how do we apply it to practice? So I can tell you that in my practice, I've actually found what this study has shown, which is the patients that by week 10, if they haven't had a symptomatic response, we do pick up, as you said, at least half of those patients by just continuing 5 to 10 more weeks. Now, I guess probably the way I would put it is, what are the patients I would not do this or continue the ozanimod are really the patients that are worse. So if their Mayo score is 3, if their calprotectin has gone up, if they're really quite ill, these are patients that I don't think it makes sense to continue. So the patients I continue really is everybody else. Either they've had a minimal response or they're not worse and they're interested in continuing this once daily therapy, which again, as we presented from these data, even include patients who've been on prior biologics. So that would have been initially a thought, is if stratifying by naive to biologics and experienced to biologics, we saw all comers actually responded whether they were on biologics or not.
Fantastic. So the patient not doing better but not doing worse and is willing to give this drug another chance, either because they like the convenience of oral medication, the safety data of ozanimod, or they have not responded to prior therapy, these would be the right patient to continue the ozanimod therapy and hope for a good clinical response. All right, I think we can go to the next abstract.
Great. So now I'm going to present the Elevate UC 12 and 52. This is now looking at a different S1P, the efficacy and safety of etrasimod in ulcerative colitis. These are the baseline demographics. And again, just to remind people, etrasimod is dosed 2 milligrams orally once a day. And you can see the baseline demographics for the Elevate UC 52 and the Elevate UC 12. You can see that the baseline demographics are nicely matched between placebo and etrasimod. About 2/3 of the patients, or at least half the patients, have extensive left-sided ulcerative colitis. You can see the total Mayo score is around 7, modified Mayo score of 7. So these are active patients. And then prior UC treatment, again, is well matched at the bottom. Those that were naive to any biologic JAK inhibitor advanced therapy, about 2/3, but that means that about 1/3 of the patients had been exposed to some other advanced therapy in the past. So getting to the bottom line data, this is a graph looking at the primary endpoint of ulcerative colitis clinical remission. On the graph, on the left-hand side is week 12. On the right-hand side is week 52. And again, you can see the darker blue is the etrasimod, the lighter gray is placebo, and you can see a statistical benefit at both week 12 and at week 52 for etrasimod 2 milligrams orally once a day in terms of achieving the primary endpoint of clinical remission. And it's important to note that clinical remission is defined as a stool frequency subscore of 0 or equal to 1, a rectal bleeding score of 0. So this means their bleeding is stopped, and looking at the endoscopic score of 0 or 1. So these are patients that are achieving not only clinical but objective improvement. And then the overall key secondary endpoints I list here on this slide, but I think if you scan across, again, the blue bars are looking at etrasimod, the gray is placebo. For endoscopic improvement, for symptomatic remission, for endoscopic histologic mucosal improvement, that combined endpoint, and clinical response, you can see that for all of these key secondary endpoints, there's a numeric superiority of etrasimod to placebo. Now, there's no statistics around these because these aren't the a priori defined primary endpoints, but I think it's easy to see that there's definitely an improvement with etrasimod 2 milligrams compared to placebo. So the key takeaways from this, at week 52, etrasimod 2 milligrams once daily, 32% of the patients achieved clinical remission, 17.9% achieved the sustained clinical remission, 32.1% of patients achieved steroid-free remission, and the serious AEs were similar between both groups in the trials. Drug-related side effects, there was one report of a second-degree AV block, Mobitz type 1, that did lead to discontinuation of etrasimod for the ulcerative colitis study.
Thank you, Miguel. So Elevate UC52 clearly show that etrasimod 2 milligram daily is an effective option for our patient with moderate to severe ulcerative colitis. So my question to you here, we're going to have a second S1PR modulator available to us. In general, how do you position this class of drug in terms of therapy for UC? And my second question would be, how would you differentiate between ozanimod and etrasimod? With ozanimod, we have a titration of the dose in the first week to prevent any potential arrhythmias. And with etrasimod, we do not have that dose titration. Would that affect your choice of one or the other? I would love to hear your thoughts on that.
Yeah, so I think to get to your first question about positioning, this is always the real clinical practical. So as all of us take this to our practices, everybody listening to this program takes that to their practice. Kind of where do you put the S1Ps, both ozanimod and etrasimod? My sense is that these being used earlier in the disease course and what I almost consider the mild end of moderate. So for me, with ozanimod, and I imagine etrasimod, I would do the same, is really the patients who've been on a 5-ASA, maybe one course of steroids. So not really failing a lot. So they've been really not on any advanced therapy. I think that's the sweet spot for etrasimod and ozanimod. That's kind of where I see it, more that earlier, milder end of moderate. Patients like this because it's, again, as you said, it's a once daily oral pill. It's easy to take. And then in terms of differentiating from ozanimod and etrasimod, again, obviously I don't have personal experience in my clinical practice with etrasimod. I think some of this in the United States is going to depend on the insurance and where this is positioned with our insurers and what's being paid for. But outside of that, to your question about not titrating, I think it's interesting looking at the etrasimod 2 milligram dose kind of right out of the gate, if you will. The question is kind of the dosing important in terms of efficacy? And will that, as we approach our clinical practices, see maybe, and again, there's no head-to-head, so what I'm about to say, I can't compare across etrasimod and ozanimod, but is it possible that we're going to pick up a little bit more with etrasimod? Again, I think time will tell. I think both are going to be excellent. Both I would use earlier in that kind of milder end of moderate UC patient is how I would position these.
So next is the very interesting adalimumab dosing interval study.
Yeah, so this is the LADI trial. This is looking at increasing adalimumab dose intervals in Crohn's. So meaning lengthening, not shortening the interval, which is usually what we've talked about. So the purpose of this is really looking at an open label randomized controlled non-inferiority study to assess the difference in clinical outcomes in patients in clinical remission receiving the conventional every 2 weeks adalimumab. So that's taking patients who are doing well in remission every 2 weeks and then continuing that conventional or increasing the dose interval to 3 to 4 weeks. So actually lengthening the interval. There are 174 adult patients in steroid-free clinical remission that defines clinical remission based on HBI, CRP, fecal calprotectin, and they had to have been on this for at least 9 months. And then they were randomized to either continue the every 2 weeks, and that's considered the control, or what's called the intervention, which is actually increasing the interval to every 3 weeks and then increasing to every 4 weeks. The objectives are the cumulative incidence of persistent or more than 8-week flares at week 48 with a non-inferiority margin of 15%. And then there are some secondary outcomes. And you can see basically the primary outcome is defined as persistent flares, 0% in control, 3% in intervention. And you can see based on the forest plot, there's no difference based on the fact that the confidence interval crosses 0. Secondary endpoints are listed at the bottom. So transient flares, escape medication, clinical remission. And although you can see numeric differences between control every 2 weeks or intervention lengthening to 3 weeks and then 4 weeks, some of these are barely touching the confidence interval as far as the line of unity. It's 0, so basically no difference between the two. So the key takeaways from this is the cumulative incidence of persistent and transient flares in the intervention group was non-inferior to the conventional group at week 48. Clinical remission at week 48, 92% versus 72% in conventional versus intervention. Patient-reported quality of life did not differ between the groups. The intervention group used more rescue medicine, which included budesonide, prednisone, thioguanine, and ustekinumab. And the safety data showed higher incidence of GI disorders, presumably that's actually active flares, but less infection in the intervention compared to the conventional group. So interesting study.
Well, this was one of the studies that really struck me, Miguel, because that goes opposite to what we typically do, right? In a lot of our patients, we go from every 2 weeks to every week. And initially, when I saw this abstract, I'm like, oh, that's what they're comparing. And we often anxious, right, as clinician to have the patient miss a dose because we're concerned about a flare, about developing anti-drug antibody to adalimumab. So how does this study change the overall patient care model that we typically have? And, taking it back to our practice, is there a subgroup of patients in your practice where you would consider a longer dosing interval with adalimumab?
Yeah, so, while this is obviously a very important, very interesting study, it's actually not changed my practice. And I'd be a little bit cautious extending the intervals. I think we've seen with the anti-TNF class, as we extend the intervals, we pick up more immunogenicity. That really wasn't looked at in the study. And over time, then we lose the ability to use that anti-TNF, in this case, adalimumab. So in my practice, it's not changing. I'm not actually extending the interval. I guess to answer your theoretic question, if there's a patient, and I'm not even sure the circumstance, where maybe it's cost or maybe it's for some reason they can't get their injection at the 2 weeks, but they can get it at 3 weeks, maybe this is helpful. But I'd be a little bit cautious because when you look at the primary and secondary outcomes with the confidence intervals, they're just barely meeting that line of unity. I imagine if there are more patients enrolled, we actually may see a difference that would favor continuing every 2 weeks. So that's just kind of my editorial comment, that I wouldn't change what I do with the every 2 week dosing.
I agree. I would have loved to see more of details about the disease location, behavior, phenotype, prior therapies, and the drug level, like you mentioned. And I also wonder if we would see more of a difference as we follow up these patients over a longer period of time. So thank you, Miguel, for these great three presentation. We're going to switch gear with Dr. Murray. Dr. Murray is going to focus on top abstract looking at JAK1 inhibitors, real life experience with tofacitinib, and the final result of UEG looking at upadacitinib in ulcerative colitis. Charlie?
Thank you, Aline. Thanks very much for the introduction. So I've got the pleasure of introducing the JAK inhibitor studies. There were lots of these at UEG Week, and the first of these today I'm going to present is a real-world evidence study looking at tofacitinib in ulcerative colitis. This was a multi-centre retrospective study to assess retention rates, in other words, durability of tofacitinib in adult patients with ulcerative colitis, and some secondary endpoints as well to assess short-term effectiveness and durability of response, but also looking at factors associated with long-term response, the proportion of those who relapsed after remission, which is very important for our patients, and whether the effects and the amount of tofacitinib dose optimization, which again is an important question. Those are the secondary endpoints. The population was 408 adults from multiple hospitals with ulcerative colitis who had received their first tofacitinib dose at least 8 weeks before study entry. In keeping with when tofacitinib really came to the market, 97% of those were biologic exposed. 30% had cardiovascular and or thrombotic risk factors, which is obviously quite a lot within this group. And the safety endpoints looked at here were hospitalization, colorectal surgery, and medication discontinuation due to side effects. So I'm going to just show you one main results study, and that's really the durability of tofacitinib in these patients. Over 40% of patients attained remission at all time points following week 8, and these patients were followed for some time after that, as you can see. And the graph in front of you here on the left actually shows durability of response in this patient group, which at 12 months is as high as 58%, and at 24 months is still 49%, with the majority of patients coming off tofacitinib in the first 6 months, and the majority of those patients, well over 40% of them, being due to primary non-response to drug, which I think is what we tend to see in clinical practice. So in terms of the other real-world tofacitinib key takeaways from this study, because it was the sort of biggest collection of retrospective data we have to date in this group, 45% of patients withdrew tofacitinib during a median follow-up of 18 months. So important to know, and certainly in keeping, I think, with clinical practice. Interestingly, higher withdrawal rates were seen in older patients and patients with higher disease activity at baseline, and that was consistent across the groups. Most commonly reported discontinuation reasons were primary non-response, 44%, as I said, within the first 6 months, and loss of response, with relatively few adverse events. 49% of patients in clinical remission at week 8 lost response. Again, important to know that these patients lose response despite being initially stable. And tofacitinib was actually dose escalated in 2/3 of patients who had lost response. And in those 2/3, 82% had clinical improvement and 60% regained clinical remission. Again, a very important message from this study that those on the lower dose of 5 milligrams twice daily may really benefit from dose escalating, and that should always be considered for them. Another very interesting point, and again from real-world data, which we don't necessarily get from drug trials, is that over 40% of patients were on higher tofacitinib dose of 10 milligrams twice daily at all time points across the study period, which again may be what we see in clinical practice, in that many patients do end up on dose escalation. In terms of serious adverse events, actually this was very reassuring. We've obviously been very concerned with tofacitinib data from the rheumatoid arthritis studies. We think we have a different population of IBD patients, predominantly younger, but even those in this study, 30% of which had cardiovascular risk factors. The major cardiovascular events were very low, and so were all of the venous thromboembolism risks in terms of pulmonary embolism, peripheral venous thromboembolism, and the expected signal which we're seeing in all of our JAK inhibitors of herpes zoster. But otherwise, very reassuring safety endpoints. Aline, over to you.
Thank you, Charlie. I really like real-world studies because I feel they're closer to what we're doing in practice. And as you know, tafasitamab is approved at the higher dose, 10 milligram twice a day for the induction period of 8 weeks, and then the recommendation is to drop to 5 milligram twice a day as a maintenance. Looking at this real-world data, where we see that there is a significant percentage of patients who could lose response after 8 weeks, and a significant percentage of patients who require us to go back up on our dosing and in order to recapture response. How does this affect your practice? Should we keep most of our patients on the 10 milligram twice a day dosing to maintain response, or is there a subgroup of patient where you would attempt de-escalation knowing that if you go back up to the higher dose, you'll be able to recapture response? What do you do in your practice?
They're really great questions. Is what we see in the clinic every day. So I think with tafasitamab, again in the UK, we have exactly the same guidance that we give the induction period at the higher dose and then decrease to 5 milligrams twice daily. I think in the very high-risk patients, when you've struggled, some of this 97% that are biological exposed that have done very badly and have finally started responding to drug, it's that group one would consider continuing on the higher dose of drug. I think as a general point with JAK inhibitors, I think we're seeing great efficacy and safety data. What we're really looking for is where the therapeutic window is for these patients. And actually, I would argue, therefore, that there will always be a group that will do extremely well on 5 milligrams twice daily. You're giving them less drug. In theory, you're exposing them to less risk, albeit low risks, as we've seen from the studies in the real-world data I've just presented. In those that are relatively stable, have perhaps had moderately severe disease, who have done well, I would always de-escalate to the recommended dosing schedule. But I think this data gives a very strong message that if those patients do start to relapse, then you should always try to dose escalate. And I think potentially keep them on dose escalation after that, because most of the, over 40% of the patients in this study were on 10 milligrams twice daily in this study period, and we didn't see big safety issues to make us concerned about that. So the second study I have to present is UEG, very proud to give this one a prize as the best abstract in the plenary session. And this was the efficacy and safety of upadacitinib maintenance in ulcerative colitis. And this was the final results from the phase 3 UAchieve study. So the purpose of the study was to assess efficacy and safety data from the UAchieve maintenance study, full intent to treat population, when upadacitinib induction responders enrolled in the 52 weeks maintenance therapy were followed through. And this population was patients that had received and responded to UPA 45 milligrams QD induction therapy at 8 weeks before randomization. And the study in this particular group was the full study of 681 patients who were randomized in a 1:1:1 ratio with double-blind, placebo and drug. And this was the phase 3 clinical trial to evaluate long-term up to 52 weeks maintenance to check safety and efficacy of UPA at doses of 15 or 30 milligrams maintenance. So important to note that a lot of this data has been published before in the Lancet, so we know about this data, but this is the extended group, increasing by another 50%, so we have a lot more data to look at now. So in terms of the key demographic characteristics of this group, the baseline characteristics were very similar in the randomized group, as you can see here, certainly in terms of Mayo scores, in terms of fecal calprotectin, and in terms of exposure to biologics and immune modulators in the past. Now, when I look at the results slide, what we have on the left is actually the original data set, which is already published. As you can see, there's a really impressive delta between placebo and 15 milligrams, and indeed 30 milligrams, and certainly a numerical increase as you go up on dose. And when we then go on to the right of the slide in front of you here, We've got an expanded group of patients, 681 patients, and actually this just shows exactly the same findings and supports the findings of the original study with more data. The takeaways from this upadacitinib maintenance study are that when compared with placebo, the key secondary endpoints were all achieved actually at higher rates in both UPA groups, so both 15 and 30 milligrams. And that upadacitinib had a favourable risk versus benefit safety and efficacy profile in this larger population. Again, an increase of 681 patients. We're not seeing any increase in cardiovascular risk, no increase in venous thromboembolism, and there is a slight increase in herpes zoster, as has been seen in the other JAK studies.
How is this study, how are these results going to change your practice in terms of recommending UPA in your patient with ulcerative colitis? And my second question is, would you have a preference in terms of the maintenance dose, the lower dose, or the higher dose? Or is there any factors related to the patient disease course, disease characteristic that will make you choose one or the other?
Sure. Thanks for the questions, Aline. I think it's very exciting. I think, I mean, correct me if I'm wrong, but I can't remember seeing deltas like this in studies to date, certainly in ulcerative colitis. Where we're going to use it in treatment, I think to a certain extent will be, there will be some regulatory control over that. I think Europe is different already to the States in that respect. I think we'll be moving the JAK inhibitors up in our treatment of ulcerative colitis generally. I don't think we have enough evidence to suggest that this is first-line course, certainly in acute severe colitis, for example. But I think that JAK inhibitors as a class becomes something that becomes very attractive very early on in the treatment of ulcerative colitis. In terms of which patient groups to treat with either 15 or 30 milligrams, for example, there was another study very nicely presented from the same data set really by Brian Freegan at UEGW, just to talk about UEG week again, suggesting that the 30 milligram group may do slightly better if you look at days of remission over a year. So if you look at the data very closely, small numbers, but nevertheless there was a signal there. So I think that we, as I said in the previous study with tofacitinib, we need to think about patients as individuals. Some will have more risk factors than others. Those with cardiovascular risk, for example, one might want to treat older patients, cardiovascular risk. One might want to treat with the lower dose if possible. But we're getting very good safety data from higher doses, and those that we think require high doses that we think need to stay in remission, as we talked about before, those in which we've struggled to get people into remission, I think that we can very safely continue the 30 milligram dose.
Thank you, Charlie. Thank you. We're switching gear now, looking at IL-23. We have 3 abstracts, and I think each one of you is presenting one. But we'll start with Dr. Iris Dotan, looking at very exciting genetic data related to IL-23. Iris?
Yes, Aline, thank you so much for this. I actually think this is very exciting, specifically showing how data from basic sciences and epidemiology and old archival samples from patients that live in prehistoric periods can tell us something about inflammatory bowel diseases. Now, we assume that inflammatory bowel diseases occur in genetically susceptible hosts and are driven by environmental factors. And we also know that genetic variants in the IL-23 receptor are strongly associated with inflammatory bowel diseases. And actually, some of these variants have very powerful protective effects in inflammatory bowel diseases. We also know that blocking the IL-23 receptor and pathway is a treatment for inflammatory bowel diseases. So the authors had sequencing data that were obtained from more than 2,000 ancient individuals from Western Europe and the Near East and the Russian steppe. And actually in 172 individuals, they also had more advanced sequencing data, and they could group them according to their ancestry, to where they lived, and additional factors. The results were actually very interesting. So the IBD protective IL-23 receptor allele was completely absent in European hunters-gatherers. And in later populations that deviated, and these were the early farmers, you started to see this allele in higher frequencies, but it was absent from genomes of the steppe population. Those would be the horseback riders and lifestyle. Now, these populations overwhelmed the farmers later on. And with their massive invasion into continental Europe, the frequency of this allele, the RS11, 20, 90, 26A, continuously decreased from what it was until it reached a level of what is reported here, about 6%. And that was quite steady until what we see today in our population. And the frequency of this allele today shows a north, south, and east-west gradient that reflects both the penetration of the steppe population into Europe and also parallels what we see today in the incidence of inflammatory bowel diseases. What is so interesting here is that hunters-gatherers and early farmers show variances in the allele frequencies of inflammation protective interleukin 23 variants. And these variants were introduced via selection when these populations moved from being hunters-gatherers into farmers. They changed their nutrition, they co-housed with animals, they were exposed to animal microbiomes and zoonoses, and this probably selected specific genetic variants. And I think that this is not only a very novel study, but it tells us a lot about the development of this rather novel condition that is inflammatory bowel diseases, and perhaps also hints to how we can treat these diseases. What do you think about it, Aline?
Well, honestly, Iris, I love this study because I think it's just fascinating to see how, the looking at the, human migration and human race evolution and going from hunter-gatherer to farmers and, being, living in the steppe versus moving into more temperate climate is really affecting our genetic profiles. I find this fascinating. And, as we struggle in terms of how do we choose the right therapy for the right patient, either as a first line therapy or second or third, how do you see the findings of this study changing how we look at testing for genetic variants and selecting the right therapies for our patients?
So actually, first of all, it's exactly what you were talking about. I think that it gives us a way of precision medicine in our population. Of course, our population is Caucasian. Half of it in my clinic comes from European ancestry. So first of all, it might suggest that some of these patients have these genetic variants. It tells you that since the decrease of the protective allele is paralleling the development of inflammatory bowel disease, it suggests, of course, what we know today, that the IL-23 pathway and that specifically IL-23 blockade might be an important tool in treating patients with inflammatory bowel diseases. And of course, it tells us what I believe will be in the coming few years, that we will look not only at populations, but also at specific patients and try to select specific therapies for these patients. So for instance, if a pathway is relevant to a specific patient, perhaps we should treat, or maybe we don't need to treat that patient if there is already a variance that is associated with protection.
Well, I think this is very exciting and hopefully the beginning of more research looking at genetic variants and how they influence IBD phenotype and onset and severity and our choice of therapy. Next, we're going to have Charlie again looking at risankizumab in Crohn's disease and more particularly delayed responders to Risa. Charlie?
Thanks very much, Aline. So I think this is a very interesting, albeit quite a small study because it only involves a few patients, looking at delayed responders to risankizumab in Crohn's disease. And from a clinical practice point of view up front, I think it's just an interesting question for how we use our drugs and those patient groups that we might persevere with treatment with. So this was specifically looking at delayed responders to risankizumab in Crohn's disease. And the study purpose was to assess safety and efficacy of risankizumab in 64 adult patients, around 30 odd in each group, with Crohn's disease who had no clinical response. They were no worse, but they had no clinical response to the 12-week risankizumab IV induction in the initial studies. And as they were no worse, they then received an additional 12 weeks of risankizumab subcutaneously in that 12-week maintenance study. And if they then had a delayed response, we then looked at the population. So this population were patients achieving clinical response to subcutaneous risankizumab at week 24 to enter this Fortify maintenance study, and they were continued on the same dose that they went in through the initial study, whether it be 180 milligrams or 360 milligrams subcutaneously, and then were analysed for clinical endoscopic improvements at week 52. So I've got limited data slides to show you here, but just to point out that in terms of clinical remission, endoscopic response, and ultimately deep remission in both the doses of risankizumab at 180 and 360 milligrams, we showed really quite impressive clinical response and remission rates, which one wouldn't necessarily have expected given how slow they were to respond. So, takeaway messages. Patients who initially did not respond to 12 weeks of IV induction treatment with risankizumab but were started on 12 additional weeks of subcutaneous drug and then maintained on that, saw clinical benefits all the way out to week 52. So again, the take-home message being there that these initial non-responders then did respond during the extended maintenance with subcutaneous drug and then maintained that through to week 52. A dose response trend was observed in these groups between 180 and 360, but the numbers are quite small and it clearly wasn't powered to look at dose response curves, but there were numerically higher response rates observed for 360 milligrams versus 180 milligrams. And generally speaking, the drug was very well tolerated and no new safety findings in this relatively small subgroup. So, take-home message here, risankizumab may not work initially in the IV phase of induction, but actually if, for a particular patient group, and I would argue it's those patients that are relatively clinical stable, haven't had any particular response to the first 12 weeks, but are certainly no worse, it may well be worth persevering with drug in that particular group because you will get some of those into remission.
Thank you, Charlie. So this brings back a little bit the same question I had asked Miguel regarding the ozanimod study. Again, patients who do not respond to the induction dosing could benefit from extending therapy further. And that goes a little bit against what we typically do, right? We initially feel that if you respond to the induction, you're going to do well. If you have zero response to an induction therapy, it's probably time to move to a different therapy or do something different, dose escalate, etc. So how does this data change your practice, Charlie? Which patient group would you say, you know what, you did not respond, but let's push it further. There's a chance that we could see some benefit. And in those patients, would you favor the higher sub-Q maintenance dose versus the lower one?
Sure. So to answer the first questions, I think, with this class of medications, we are seeing patients that are capturing response a lot later than we might normally do. But to some extent, there's always a patient group with most biologics that will capture response eventually. I think the patient group that I would consider continuing drug after 12 weeks and give the second maintenance therapy to really would be those that have not responded but are not too unwell and are certainly no worse. And how we assess them, certainly it would be good to get some imaging. We're using ultrasound, for example, the small bowel more and more in the UK with biomarkers as well. But really we're just making sure the disease is not deteriorating, because I think if the disease is not deteriorating, the patient feels relatively well, then I would then push on with 12 weeks of subcutaneous dosing for the next maintenance phase. The ones that I then continue on would have to have responded, and of course we can objectively assess that. But in this patient group that there really has been a slow burn, you'll often be told by the patient that finally they're starting to feel better, having not really had any response for some time. In terms of the very specific question about the drug maintenance, I think we are going to be licensed, certainly in the UK, for 360 milligrams as the maintenance dose anyway, so we would be using that. It's only on a named patient basis at the moment, but we will be able to use the drug, we hope, very soon.
Charlie, I think the key here is to use common sense and assess the patient, and if we're able to extend therapy and not have to switch and lose another treatment option, it would be great. Next, Miguel. We're back with Miguel, looking at mirikizumab in Crohn's disease and looking at a different aspect of in terms of study endpoints, looking at the improvement of fatigue and patient-reported outcome in patients treated with MIRI in Crohn's disease. Miguel?
So I think one aspect, just to point out, at UEG week, we discussed, and there was a lot of discussion about the symptom of fatigue in IBD, in other diseases as well. So this was a study that I was involved in, looking at mirikizumab and fatigue in Crohn's disease. The purpose of the study was to assess the association between the changes in patient-reported outcomes and also the changes in fatigue. We used a FACIT-F survey. So for those that aren't familiar, that's a survey that measures fatigue. And we did this in patients diagnosed with moderate to severe Crohn's who received mirikizumab as part of the phase 2 study. 191 patients were diagnosed with moderate to severe Crohn's. They had to have had disease for at least 3 months, didn't have an adequate response to conventional therapy, and ultimately they were randomized to either placebo or one of 3 arms of mirikizumab, 200, 600, or 1,000 milligrams IV every 4 weeks. And then at week 12, the placebo was crossed over and re-randomized to mirikizumab. So I show you here the study results. This is looking at mirikizumab and fatigue PRO in Crohn's disease. This is showing that there's a good correlation of FACIT-F, so fatigue improvement, with changes in patient-reported outcomes at week 52 of the induction period. And you can see the different domains that were looked at in terms of quality of life scores, emotional, social, and down the line, even including abdominal pain. So I think it's interesting that fatigue really did track with all of these patient-reported outcomes. And the takeaways are that the improvements in the fatigue score and the FACIT-F responses at week 12 and 52 were correlated with the overall emotional, social, systematic, and bowel symptoms in these patients. Correlations between fatigue and PROs at the end of the induction therapy at week 12 were actually similar to what we saw in the maintenance week 52. Increasing FACIT-F scores were correlated, and decreasing abdominal and physician global reported scores at the end of induction and maintenance phases. So mirikizumab has been shown to be safe, effective, and well tolerated in patients with Crohn's disease. And I think it's interesting that fatigue tracked as an improved score in PROs in this mirikizumab study. Yeah, so I think the overall question is, have we just not looked at fatigue with our other therapies, and would we find the same outcome of fatigue? And now that this has become such an important topic, we're starting to look at it. And I think going forward, we're going to see this included with other studies and other therapies. So I'm a little hesitant to say that it's specific to IL-23 or a specific cytokine. I will say, though, to your prior questions, my sense, and when I see patients with fatigue, obviously we rule out the things that are reversible. So anemia, certain vitamin deficiencies. But probably over half the patients that I see in my practice, and this has also been found in survey research studies, report fatigue as a primary symptom with their IBD. And then this really speaks to, is this a cytokine driven? Is this almost an extraintestinal manifestation? So when I talk to my patients, I almost say it that way. I say, this isn't in your head, this is real. This probably is some extraintestinal manifestation that we're just starting to understand, as we do with like arthritis. And I think it's interesting that maybe some of these cytokine-based therapies will improve fatigue. I do monitor this in our practice. I do validate this as a real symptom for our patients. Sometimes this also overlaps with psychosocial depression and other factors. We do have therapists who are involved in our practices who report fatigue at a very high rate. So an important study, an important symptom, and I look forward to future studies on this as well.
I agree. I think, often the frustrating part for both the patients and the clinician is when we ruled out the cause that we can do something about, like you said, the active inflammation, the anemia, maybe other problems like thyroid disease, etc. And then many patients are left with fatigue despite control of the disease, and it can be very frustrating. So hopefully we'll have more studies and data on how to manage and approach fatigue. Next, we're going back to Dr. Dotan, who is going to present two very exciting abstracts. One is the maintenance study after induction of remission in patient with UC with combination therapy of guselkumab and golimumab, and then a comparative study of the efficacy of Vido versus UPA in inducing remission in UC.
Thank you. So we'll start, of course, with the Vega study on guselkumab and golimumab in patients with ulcerative colitis. Of course, we all remember that Vega was a proof of concept 12-week study that demonstrated the dual blockade of interleukin 23, that was by guselkumab. Clinical response was the primary outcome. And it was more effective when it was combined versus either monotherapy alone. Here, the authors presented the efficacy and safety of combination induction therapy for 12 weeks, followed by guselkumab maintenance, versus guselkumab or golimumab monotherapy through week 38. There were 214 patients that had ulcerative colitis, moderately to severely active, and that were TNF inhibitor naive. And they were randomized either to guselkumab and golimumab induction, and then moving to guselkumab 100 milligrams subcutaneously every 8 weeks, or patients that were treated for the first 12 weeks by guselkumab continued 100 milligrams subcutaneously every 8 weeks by guselkumab, and patients that were treated in the 12-week induction Vega study by golimumab continued golimumab subcutaneously 100 milligrams every 4 weeks. So this all went until week 38. And what you see here is the clinical remission outcomes. On the right side, you see the 38-week outcomes. And on the left side, you can see the 12-week Vega induction study. Clinical remission was defined as a Mayo score of 2 or lower with no individual subscore above 1. And you can see in the gray bars that patients that were induced by golimumab and guselkumab and then continued on guselkumab only until week 38 had significantly higher clinical remission rates compared to the ones that were treated with golimumab alone, and higher rates than the ones that were treated by guselkumab. So they actually maintained the good outcomes that were shown in the first 12 weeks. Combination therapy, golimumab and guselkumab, that was followed by guselkumab monotherapy, led to significantly greater clinical remission, as we have seen, endoscopic improvement, and even normalization, meaning a Mayo of 0, histologic remission, and histoendoscopic improvement rates at week 38 compared to either guselkumab or golimumab alone. Safety and safety events were comparable in all treatment groups. They were looking at adverse events, serious adverse events, infections, and specifically serious infections. So I think this was, of course, it created a lot of attention during that session and throughout UEGW. What did you think of this study?
So, Iris, I think this was a great study because it really changed our concept of when should we use combination therapy. I think in recent years, we've all had in our practice, and there were small case series presented where we used combination of biologic and small molecules in patients that where the UC did not respond or had a minimal response to several effective therapies. So it's almost like we're using it as the end of the line. And with the Vega study, it's showing that inducing remission with combination of 2 biologic in patients who were, bio-naive, anti-TNF naive, is more effective than a monotherapy alone and could increase our overall response rate. So I think this is kind of shaking our perspective. So my question to you is, what's next? Is there a subgroup of patient that you would select to use a combination therapy as an induction, or are we not ready yet? Are we there yet, or are we not?
So I agree with you that this is a change of concept, right? Not waiting for treatments to fail and then add one to the other, but to start with combination and then go to monotherapy. And importantly, it's the first time that we try this in ulcerative colitis, right? We are already starting to think about it in Crohn's disease, but in ulcerative colitis, this was tried on for the first time. So I think that the answer is, of course, more complex than just saying, okay, let's combine. In patients that are TNF inhibitor naive, and this was the patient population that was selected for VEGA, I think that in a subgroup of patients, and in the results, the authors also showed that in the combination group, some of the patients, a subpopulation of the patient, had more severe disease. So I think maybe patients with ulcerative colitis that have higher Mayo scores, that have more severe disease, maybe in those patients we would like and we would opt to combine therapies and only then move to monotherapy, which may have a more favorable safety profile. For instance, of course, we need to look at longer term outcomes of VEGA that are starting to be accumulated and to be presented in order to show how beneficial is the combination. And that will tell us and answer your question, Aline, are we there yet? It also relates to what we had just discussed, which was a controlled trial, prospective, and so on. We will not have every combination of every drug that we are using in head-to-head trials, right? So in order to bypass that, different authors are trying different approaches. So here the purpose was to do indirect comparison of efficacy and safety outcomes that were based on placebo-anchored, a matching adjusted indirect comparison between upadacitinib and vedolizumab. In this case, both are therapies for patients with moderately to severely active ulcerative colitis, taking advantage of phase 3 induction studies like UACHIEVE and UACCOMPLISH for upadacitinib and Gemini for vedolizumab. Patients that were treated, they took diagnosis of ulcerative colitis for more than 90 days prior to baseline and adapted Mayo score of 5 to 9 in the UPA trials, and a diagnosis of ulcerative colitis for at least 6 months prior to enrollment and full Mayo score 6 to 12 in the VIDO trials. And the baseline patient characteristics from the UPA trials were weighted to match those in the Gemini. So a few statistic intervention that we will need to remember when we discuss the outcomes. And in the study, of course, patients received upadacitinib 45 milligrams QD for 8 weeks with disease evaluation at 8 weeks. And in the Gemini study, as we remember, patients were treated with vedolizumab 300 milligrams intravenously at weeks 0-2 with disease evaluation at 6 weeks, or the corresponding placebo, of course. And what we can see here in this table is that when we're looking at upadacitinib versus vedolizumab for induction in patients with ulcerative colitis, clinical response, clinical remission, or endoscopic improvement that are stratified according to whether patients were bio-naive or bio-failures, you can see that in directly comparing UPA versus VIDO, to summarize this complex data shortly, then the proportion differences were higher in favor of upadacitinib, both for clinical response and clinical remission, as well as for endoscopic improvement. On the right column, you can see the numbers needed to treat for each situation. The authors also try to assess safety risk differences, and you can see here the adverse effects of upadacitinib versus vedo, the serious adverse effect, and any infection were not significantly different between the various groups. And actually, the key takeaways here from, again, an indirect treatment comparison, I suspect we will have more and more of those as we have more agents now, suggested that upadacitinib had a higher efficacy during induction treatment compared to vedolizumab in both the bio-naive and the bio-failure patients with moderately to severely active ulcerative colitis, which achieved a higher proportion of them achieved clinical remission, clinical response, and endoscopic improvement after the weighing. And the safety outcomes, including the rates of adverse events, serious adverse events, and serious infections, were not significantly different between the groups. So as I believe that we will see more and more of these comparison, we need to be able to analyze the outcomes of such abstracts, and of course to think what will it do to our clinical practices. What do you think about that, Eileen?
Well, this, like you mentioned, Iris, it's so important to try to understand which therapy is more effective for my patient while keeping safety in mind. So, at first view, looking at this data, I mean, it seems like UPA is a winner here. But the authors were very good at trying to weight different components of the patient demographics and disease severity and activity in comparing the two data. Translating that in our clinical practice, vedolizumab has been a favorite in many subgroup of patients, mainly those at high risk of infections, patient had a prior history of cancer or skin cancer or other type of cancer, older patient, frail patients, and also many other patients who really prioritize safety in their choice of therapy. So putting all this together, what we're seeing in practice, what we're seeing with this data, how do you translate this data to your practice? How do you discuss it with your patient, and how does this change how you choose therapies in your patients with moderate to severe UC?
So first of all, I think we should still, despite the efforts, of course, of the authors to be very careful about this, we need to take this with a grain of salt. And of course, this is indirect comparison, and the inclusion criteria of patients in the studies were different, and the evaluation points were different. So we need to remember that. Having said that, we see here induction studies, so we see the rapidity of the effect, and we see certainly there is a suggestion here for a favorable effect of upadacitinib. So today, in coming into an era of small molecules, after having for the last 20 years mainly the monoclonal antibodies, we see here that we can discuss with patients, as you suggested, we can discuss small molecules, in this case upadacitinib for patients with ulcerative colitis, with demonstrated rapid effect that also looks favorable when compared to, of course, what was ruling in the field of ulcerative colitis in many areas of the world. So definitely there is something more to discuss with patients. First of all, we need to take that into account. And then we can discuss with patients, what does that mean to be treated for several weeks with specific small molecules, to try and see if this will be associated with some benefit. And if not, we can discuss other treatment options. So for sure, we need to take that into consideration, and not to have only one thought and one drug in our minds when we're treating patients with moderately to severely active ulcerative colitis. I think this is a great advantage for our patients and for ourselves, that we have more than one option to treat these complex patients.
I agree, and I think all of us in our clinical practice, we've seen and we're impressed by the rapidity of action of the JAK inhibitor class, and sometimes that's what we need in our patients, versus looking also at the long course, right? Inflammatory bowel disease is not a fast race; it's a marathon. It's a unfortunately lifelong disease. So balancing that with efficacy and safety of other drugs. So these are interesting times, like you said, that we have different tools in our toolbox that we can offer our patient, and really balance, the safety and the efficacy, the rapidity of onset, the long-term tolerability, and maintaining response to drugs. So all these are factors that need to be considered when we're making a decision, and really reach a shared decision with the patient that we're treating. So on that note, I would like to thank everyone for being here today from all around the world, different time zones, but I think we all agree that UEG was a fantastic meeting, and that brought, amazing research to all of us clinicians to help us improve how we treat our patients with Crohn's disease and ulcerative colitis. And I hope that next year we'll all be there live in person and really experience everything that UEG has to offer. Thank you everyone again for joining us today. Please make sure to claim your CME credits by completing the post-test and evaluation form at the link on the screen. And do not forget to join us this coming Monday, January 30th at 2 p.m. Eastern Time and 7 p.m. GMT for our live Q&A with our fantastic IBD faculty. If you have questions, start putting them below the video. We'll answer them on Monday. Keep bringing those questions and let's have a good, lively discussion on Monday to help us manage our patients with inflammatory bowel disease in our clinical practice.